Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and it is great honor, really. Today, we have Professor Kaider from Israel. He's a well-known bariatric surgeon and great teacher. In many different international conferences, really, I learned a lot from Professor. And it is really great honor for me. So, Professor, accept our invitation and hope today our session will be very fruitful. So my humble request to all of my viewers, if you have any question, you can ask in comments, and also Professor is here. So I will convey your message and you can directly ask your question from Professor. Professor, I will not take your time. Over to you, sir.
Thank you very much. And really, I'm delighted by this great honor to have our connections. I think it is a new connection with Dubai and with the group of laparoscopy, world laparoscopy and robotics. I see it as a great opportunity for cooperation, for exchanging knowledge, learning one from another, and continuing the excellence in bariatric surgery. So I will do a short, brief presentation of myself, describe my experience in bariatric surgery. I started the bariatric surgery in 2003, and this is my caseload. Over the years, I have done, you can see here, most of my operations, the majority were sleeves. At the very beginning, I started from the gastric bypass. So my first bariatric operation was actually the gastric bypass. After that, I did a mixture of bypasses and sleeves and a little bit of bends and also of BPDs. In recent years, the most common operation I perform is a one anastomosis gastric bypass and a SADI, loop duodenal switch. But obviously, I continue performing Roux-en-Y gastric bypass and sleeve gastrectomies. I do not perform any more BPD scopinaro. I stopped doing this. And I rarely still perform the duodenal switch, but I prefer the SADI operation and the mini gastric bypass. So my training was received in the Los Angeles County Hospital of California under Dr. Katkuda, Nemir Katkuda. I think one of the best laparoscopic and in general surgery, one of the best teachers. I owe him a lot. This is me in front of the hospital 18 years ago. When I came to him for the training, we performed mostly a hands-on Roux-en-Y gastric bypass. This was maybe 90% of all bariatric operations. And we performed them only by Higa technique. He had changed a little bit the technique, but in general, it is described in the literature like a Higa technique, completely hands-on gastrojejunostomy, 4 layers, 2 posterior layers, 2 anterior layers. But after I finished the fellowship, I started learning also some different techniques, and I learned a linear technique, and I also did some modification to this technique. I saw Professor Rosenthal in Florida. I saw several other operations, Ikramuddin, that I think at that time he was, and now he's on the north in Minnesota, but I saw him before he came to Minnesota. And we did the evaluation of our results in 2014, so I will present it a little bit here. And I think that doing a Roux-en-Y gastric bypass with a hands-on technique is the best, really the best teaching procedure for any bariatric surgery, because you can use this ability to perform a hands-on anastomosis in every difficult situation, which we'll describe a little bit later. Indications, I think gastric bypass, Roux-en-Y gastric bypass can be done in almost every patient who needs a bariatric operation, but especially it is very good as operation for reflux esophagitis patients, in patients with hiatal hernia causing reflux, in patients after gastric bends with esophageal dysmotility, in patients with Barrett esophagus. And there are some contraindications for Roux-en-Y gastric bypasses. I think peptic ulcer with complication, it is, in my opinion, a strong contraindication if patient has already a bleeding from the peptic ulcer, from the marginal ulcer. When there is a severe anemia, smoking is a relative contraindication. It's not an absolute. Patient who needs to take NSAIDs, aspirin, high doses, Crohn's disease is a relative indication, but I think the most important one, absolute contraindication, is the patient who underwent many operations on the stomach, on the bowel, small bowel resections, multiple laparotomies, gunshot wounds, resections. For example, patient who had bowel obstruction and had an operation by laparotomy, a resection of small bowel. Those patients in whom I think any bariatric operation that requires measuring of the small bowel is dangerous. So in those patients, I think sleeve is the best option. So I will tell you that there is a paper in 2003 that was published by Philip Schauer, and I think this is one of the best papers ever published about the gastric bypass. This is one of them. Another one is the techniques of different techniques in Roux-en-Y gastric bypass. He describes this very, very intelligently and very systematically. He describes the different sequences when we do first the jejunojejunostomy and then gastrojejunostomy, and then again we change positions and different techniques, hands-on and linear stapler and circular stapler. There is a table in this paper, not in this, but in the paper that the name of the paper is The Current Technique of Gastric Bypass, also by Philip Schauer. He describes the benefits and the downsizes of every technique. I encourage you, I will skip all this, but I will only get to the point. So in 2014, we published some paper in our local journal about our short series, but at that time, it was 511 consecutive patients who underwent Roux-en-Y gastric bypasses. And you see that some 95 of them, it means almost 20% of the patients were redo gastric bypass, conversions from sleeves, from bands, from VBGs. They were excluded. So we did these statistics on only 420 patients of primary gastric bypasses. So primary gastric bypass, you can see 416, age, BMI, weight, and the technique is as following. We do the jejunojejunostomy first. We do a stapled jejunojejunostomy with a linear stapler, only one firing of a 60 or 45 millimeters stapler. After firing, we close the common enterotomy by a running suture of 3-0 Prolen. Out of the series of, now I have almost 1,000 cases of Roux-en-Y gastric bypasses, I saw only one leak from this site, from the jejunojejunostomy. I think it is a very safe anastomosis, and when you close it, by suturing, hands-on suturing, you avoid the narrowing and you avoid the kinking, and this is a very safe anastomosis. So the next step is a gastrojejunostomy. So this is close to the technique that I perform today. I perform it with a side-to-side gastrojejunostomy on the anterior wall of the pouch, and with the 30 millimeters stapler, and also I close it with a running Prolin 3-0 suture in 2 layers. But as I mentioned at the beginning, I sometimes perform a hands-on anastomosis, and we will discuss it a little bit later. So in this group of more than 400 cases, we had a conversion in only 2 patients. One was after severe pancreatitis, so we could not dissect the posterior wall of the stomach. And after firing of the first stapler, there was a huge hole in the stomach, so we had to open. And another patient had also severe adhesions after hepatic resection for hepatocellular carcinoma. So the mean operative time from this series was 86 minutes. In the first 100 patients, the mean operative time was, you see, it was almost 2 hours, a little bit less, a little bit more than 2 hours, 2.5 hours. In the last 125 patients, it was 75 minutes. In the last 50 cases, it was around 16 minutes. I can say that it was, now it's 8 years later after this series was collected, the average time for Roux-en-Y gastric bypass in my department is about 50 minutes. You can see the operative time, how it becomes shorter and shorter. This is in minutes, and this is the number of cases. And there were 7.7 major perioperative complications. So the most common complication was bleeding, leaks encountered in 4 patients out of 420 patients, and none of the patients stayed in the ICU, and there was no mortality out of those cases. So overall, there were 4 leaks. It's about 1%, a little bit less. But what is important that 3 leaks out of 4 were encountered in the 100 first cases. And in the last 300 cases, there was only 1 leak. So the leak rate goes down after we can overcome the learning curve. On the opposite, the leak rate in the patients, out of 90 patients that were operated up to 2014, there were 5 leaks. And you can see that in the redo gastric bypass, the leak rate is 5 times higher. We will discuss those complications because there are questions that we have to discuss about the bleeding, about the leaks, strictures, torsion of the anastomosis, gastrogastric fistula, port side hernia, internal hernia. So we will discuss it.
Sir, we will discuss ahead. So because we have some questions, if you at this stage, you can stop sharing.
So this would be the last slide. I will only say that there are many papers that say that for Roux-en-Y gastric bypass, the learning curve is about 100 cases, but there is also a paper in the Annals of Surgery, some maybe 5 or 7 years ago, that says that it could be even 500 cases. Obviously, it depends on the surgeon, on his previous experience, but after we overcome the learning curve, we can perform Roux-en-Y gastric bypass in patients even after Bilrot 2. And that's my experience, that I have performed several gastric bypasses after gastrectomy for cancer with Billrod-2 open retrocolic anastomosis, and in patients after liver transplantation and after kidney and pancreas transplantations and after liver resections for cancer. And I think this is the sign of a surgeon that already overcame his learning curve. So now I will stop sharing, and we will start discussion.
Yeah, sir, excellent really, and also your excellent demonstration about Roux-en-Y gastric bypass. And as you have mentioned now, sir, this will be stop sharing upside, just you can see. So you can see upside. So there will be, when you just rotate your mouse upside, there will be a stop sharing.
Where is that? Ah, yeah, okay, I see.
Yeah. So excellent, sir. Excellent demonstration about Roux-en-Y. And now I am talking with someone who has experience of Roux-en-Y gastric bypass about 2 decades. And definitely during this journey of bariatric surgery and especially Roux-en-Y gastric bypass, you have evaluated your technique. So, but before going to talk about technique, I have some question regarding pre-op or patient selection. You have mentioned some relative and absolute contraindication. So what is your opinion about someone who is suffering with cirrhosis or in any stage, so child A, child B or advanced? Because you have not mentioned in your relative or absolute contraindication. Have you any concern about such a situation?
Excellent questions. And I have actually performed, I think, about 16 operations on the cirrhotic patients. And we published it just recently. And I can say that there were both sleeve gastrectomies and Roux-en-Y gastric bypasses. And from my experience, gastric bypass is a more dangerous operation in a cirrhotic patient. So first of all, regarding the child staging, I think the patient who is child B, it is too dangerous to perform any bariatric operations on him. And we can only allow, I think, the danger of the complication only on a child A patient. I think child A patient deserve bariatric operation if he suffers from morbid obesity, but I think the good operation for him is a sleeve gastrectomy and not a gastric bypass. Although I'm saying that I did perform, but there were maybe 60% of complications. One of the complications was a leak that a woman, she recovered from the leak, but it was really a complicated case. Another patient was bleeding. And another patient had a severe bleeding after 1 year after Roux-en-Y gastric bypass, severe bleeding from a marginal ulcer because he was receiving aspirin and heparin because he had a hepatic artery stenosis. He underwent liver transplantation with a hepatic artery anastomosis that was strictured. So he needed to get aspirin and heparin together. So he bled severely from marginal ulcer from the gastrojejunostomy. And this is something that we probably will not see in a sleeve gastrectomy. So I think the best operation in a cirrhotic patient is a sleeve gastrectomy, and cirrhotic patient is a contraindication for Roux-en-Y gastric bypass.
Sir, according to your opinion, if a patient is suffering with osteoarthritis and our patient need NSAIDs for a long time, so in such a situation, you prefer a sleeve, not Roux-en-Y gastric bypass?
Yes, I think the preferable operation in this case would be a sleeve gastrectomy.
Yeah.
you know, sometimes we can have a patient who is already after sleeve and he requires again a gastric bypass. That's a more difficult case, and he needs to take ibuprofen or something, some non-steroidal anti-inflammatory. Then it's a more difficult case. But I think in this case, if he has severe enough obesity, probably SADI would be the better option than the gastric bypass. Not Roux-en-Y gastric bypass and not mini gastric bypass, because both operations are prone. Those are ulcerogenic operations.
Absolutely
So,
agree. Yeah. Sir, according to your opinion, have you any age limit for Roux-en-Y gastric bypass, like in adolescents or in older age, like after 65 years? Have you any age limit?
I think there is no, in my opinion, there is no age limit. I think Roux-en-Y gastric bypass is a very, very safe operation. If it's done properly, it has a very low complications rate. There is no cases, almost no cases of severe malabsorption, of patients suffering from hypoalbuminemia. So I think it's very good for elderly patients. And my eldest, the most old person that I performed on him a gastric bypass was 76 years old. I know that there are even older patients recorded in the literature, but my oldest one was 76. So I felt very safely performing Roux-en-Y gastric bypass on him. And in young, I think sleeve is a better operation for adolescents, because they are still not developed psychologically, and they will not, I'm not sure they will take vitamins, and I'm not sure they will follow the dietary instructions as we need them to do. So I think this option is less obligating, is less obligatory for them. Sleeve gastrectomy probably better, but after age of 18, I think there is no problem. I think Roux-en-Y gastric bypass is a good indication for a patient after 18 years of age.
Sir, one question regarding osteoporosis after menopause. So a lady after menopause and symptomatic osteoporosis, symptomatic, and have you any protocol to rule out osteoporosis like densitometry, or you go, it is necessary, and if proved yes, there is osteoporosis, again you will go for Roux-en-Y, or no, you will prefer to go for a sleeve gastrectomy?
So it's I think it's debatable, because Roux-en-Y, it is a malabsorptive operation, and it is followed by some hyperparathyroidism, elevated levels of PTH and low levels of vitamin D. And if a woman has already a proven osteoporosis, then it's a good question, because sleeve may be a good option for her too. But if the osteoporosis is under treatment, and she gets a treatment, and she has a program to stop to prevent the exacerbation of osteoporosis, maybe it's not contraindicated completely, because we have to take into consideration also the side effects of the sleeve in the elderly patients, like gastric dysmotility, severe reflux. And we know that elderly people, age is a negative prognostic factor for weight loss. So I have seen some patients, elderly patients, who have underwent sleeve and they did not lose enough weight. So in this regard, I think gastric bypass is better. So I think it is not an absolute contraindication, osteoporosis, but if there are like pathological fractures, we can see some patients with vertebral pathological fractures because of the osteoporosis, then I think it is a contraindication. That's we don't want to exacerbate this condition.
Sir, you have highlighted excellent point. So regarding gastric dysmotility in older age, so this is a good point. So in such a case, in which age, and also especially in a patient with diabetes, because diabetes long time also causes gastroparesis. So you think these cases are not good case for sleeve gastrectomy, and there will be more chance of GE reflux?
I think so. I think that gastroparesis, and especially diabetic gastroparesis, it is a good case for gastric bypass. I think the gastric bypass is the best operation for patients who has gastric dysmotility or gastric and esophageal dysmotility, because I think there is almost no problems in Roux-en-Y gastric bypass, no reflux, no problems, even in patients who have a conversion from sleeve due to all the possible problems that we have in sleeve. They are usually resolved in a very high percentage of cases after conversion to Roux-en-Y gastric bypass, because when we perform a Roux-en-Y gastric bypass, we have a wide gastroenterostomy. It is not an obstructive operation, and the small bowel motility usually is very good. So the emptying of the gastric stomach, of the gastric pouch, is very good through the gastrojejunostomy. So I think for this case, you know that Raul Rosenthal from Florida, who is now the chief editor of the SOIRD, he also pioneers some operation for, he has a series of patients that he had performed as Roux-en-Y gastric bypass for gastric dysmotility. So this is only one, I think, one more indications for bariatric patients that is really in favor of Roux-en-Y gastric bypass.
Sir, personally, I have no experience. Just question. So can we measure this gastric motility before surgery? Have we any instrument or something like this? Or you do?
Yeah. If you have a suspicion or a question about the motility, we can perform the gastric emptying. It is a scintigraphy. Patients they ingest the radioactively labeled. It could be eggs, it could be soft eggs, or it could be a poultry. The how do you call the meat of
Mutton or something they can eat.
of turkey, yeah,
Turkey, yeah.
Of broiled, how do you call them? The small, the one that.
Yeah, turkey. So it's okay, and yeah.
Yeah. So there are normal emptying time of the for the normal gastric motility, and there are they measure the emptying. So it should be something like 50% of the food should be already gone from the stomach after, I think, after 1 hour or something. So there are numbers for normal emptying of the stomach, and if there is a delayed gastric emptying, then we can have a diagnosis of gastroparesis.
Sir, so, this is excellent. This is why we have started this interview series, because every interview, every session, personally, I have learned a lot, and it will be great message for my viewers, because we always think about this in older age when patient is old, and then, okay, sleeve is better, and because there is a less complication, but we must also think about this dysmotility. If there will be dysmotility, again, it will create issue for the patient. So this is excellent. Sir, what is your protocol about pre-op endoscopy and also H. pylori eradication?
In a patient that is asymptomatic, has no complaints on any dyspepsia, any reflux, any no history of peptic ulcer disease, not taking any proton pump inhibitors, we propose them to perform either a barium study of the stomach, gastroesophageal study, or endoscopy. We do not make them. We don't have any preference. We allow them either do this or that. But in a patient that has a symptomatic complaints of whatever, it could be dyspepsia, reflux, vomiting, or a patient who has a revisional operation, who is supposed to have an operation after sleeve, after bend, we perform always both, and endoscopy and barium swallow study, because we want to see the anatomy. Barium swallow will show us better the condition of the upper part of the size of the hiatal hernia, functional reflux, the going back of the barium into the esophagus. We can see to what height it goes to the lower third or even to the upper third of the esophagus. And endoscopy will show us the degree of the esophagitis, of the gastritis, of the peptic ulcer. So in a patient that is asymptomatic, we have no preference. We can rely either on gastroscopy, endoscopy, or barium swallow. But in a symptomatic patient, we ask them to perform both. Also, in a patient who has a suspicion of gastroparesis or problems of esophageal motility, we also ask them sometimes to perform pH metry and gastric scintigraphy, emptying of the stomach. And regarding the Helicobacter pylori, if a patient had a Helicobacter pylori positive test, we ask them to make an eradication before the Roux-en-Y gastric bypass. And I think it's worthwhile to mention that if a patient is a candidate for a sleeve gastrectomy, we do not insist on eradication of the Helicobacter, because when patient has a sleeve, this is less important. In sleeve, there is a lower chances of having gastric ulcerations.
Yeah, sir, excellent. Sir, so now we will talk about some technical points. Definite, as you have mentioned during this your journey of Roux-en-Y gastric bypass in this about 18 years, you have changed your technique. Initially, you were follower of Higa technique, that is retrocolic, and so with the passage after, and also hand-sewn gastrojejunostomy. So you have changed your technique with the passage of time. So you have mentioned, and also you have shown. So what's my question now? My question is about BP limb. So what is your criteria for BP limb? Age, BMI, or comorbidities? If patient is just imagine 50 years old, so BMI is 50, 55, and diabetic patients. So have you any criteria, or no, you will go ahead for all of the patients with any type of BMI or age?
So there are several, this question contains several questions, and the decision tree for me is relying on several important facts. So the first fact is the BMI. We know that BMI is an important factor for the success of the operation, and when we have a patient with a BMI with a super obesity of above 50, the success rate of the Roux-en-Y gastric bypass is not as it is in the patient that has BMI below 50. In below 50, the failure rate is maybe 10% only. But in patients with a BMI of above 50, it could go up even to 40%. So there are so many papers written about the limb length and the Sugarman and the Porris, and now we have even you know that last month there was a paper in the SORD from Nimeri, a review paper about the limb lengths in Roux-en-Y gastric bypass. Excellent paper. They concluded that limb lengths in a Roux-en-Y gastric bypass, total alimentary limb, it includes the Roux limb and the common channel. It should be to completely avoid the malabsorption, malnutrition, it should be more than 4 meters. On the opposite, I think that if a patient has 7 meters bowel length, total small bowel is 7 meters, the Roux limb of 100 centimeters and the BP limb of 50 or 100 would be not enough. So my tendency today, when I operate a patient who has a BMI above 50, is to measure the whole small bowel and to make a BP limb, if it's possible, if he has a small bowel longer than 5, and most of the patients have longer than 5 meters, to perform a biliopancreatic limb of 150 and the Roux limb to perform of 100. So we have BP limb 150, alimentary limb 100. So in total, we have partial malabsorption in 250 centimeters. When I started, I was performing in a patient with BMI less than 50 an alimentary limb of 150, and BP I was always performing 50. But after several years, you can see patients that come back and they ask to lose more weight. So they are not happy. They say, I did not lose enough. I want to have another operation. It's not very easy in a Roux-en-Y gastric bypass. So I changed with time, and now I do a longer biliopancreatic limb, either 100 or 150. BMI below 50, I do 100. In BMI higher than 50, I perform BPL of 150. Alimentary limb is always 100.
Sir, excellent, sir. Sir, definite. So now you are going to touch MGB, because we will also talk about this, and also I will highlight your data at the end, and I very interested to hear from your side. So just now we also talk about some technical question about hiatal hernia. If a patient is suffering with large size hiatal hernia, not paraesophageal, just hiatal hernia. So what is your protocol? Are you repair? Are you do hiatoplasty in such a case? And which size you prefer to do hiatoplasty?
If a patient has a, on the contrast study, you can see very small, like 1-2 centimeters hiatal hernia, I don't touch it. And he has no symptomatic reflux. So in this patient, I prefer not to touch the hiatus. And what is important, I think, when we have a small, very small and narrow gastric pouch, the patient will not have any reflux, because small size of pouch will prevent production of the acid, and the pouch that is narrow, that we don't include the fundus in the pouch, will prevent the production of acid. So I think the reflux will be abolished by only performing a gastric bypass without repairing the hernia. But on the opposite, if the patient has a significant hernia, and I say significant, I believe it's above 3-4 centimeters. or sometimes patient can have even more, 5-6 centimeters sliding hernia, usually he will suffer from reflux too. Then I think it's mandatory to repair the hernia. And what I perform, I perform a posterior cruroplasty by 3, 4, maybe even 5 interrupted sutures. And if it does not close enough, the hiatus, I would also do the anterior cruroplasty by 1 or 2 sutures of non-absorbable eti-bond usually.
Yeah, sir, excellent. Sir, one of the nightmare that is also a challenge for a surgeon is internal hernia after Roux-en-Y gastric bypass. And one of the way to prevent this internal hernia is closing the defect. One question, your protocol, are you close the defects? And if you are closing, so which technique you prefer? This is interrupted suture or pierce suture?
From the beginning of my experience in the Roux-en-Y gastric bypass, I was closing only the lower defect. JJ intermesenteric defect.
Yeah.
And despite that, I saw I would say, not a small amount, not a small number of patients having a hernia, even in this defect. But with time, I also saw that there are patients who comes from the Peterson hernia. And I think now it's probably 7, 8, more than, it's 7 years that I close all defects, because I saw really disastrous complications of internal hernia, necrotic bowel, and what I also can mention that I saw one complication that I know I'm guilty in this complication, because the patient that I did not close the Peterson, he came with a Peterson hernia, and I performed a repair of the Peterson hernia and I closed the defect. But the patient came 1 week after this operation with a severely distended abdomen, and I operated on him. It was not possible to perform laparoscopic operation anymore. It was an open operation. And the reason for his bowel obstruction, he was severely dehydrated, in a malnutrition already, because he did not eat for maybe 2-3 weeks, because at the beginning he was suffering from the Peterson. Then I performed the closure of the Peterson, and then he came a little bit more than 1 week after the previous operation, and there was a kinking. I caused a kinking of the mesentery by closing the Peterson. I did too much closure of the Peterson space, and I caused a kinking of the bowel at the area of the mesentery. So, and I think if it was closed on the first time, during the first operation, during the first gastric bypass, maybe this complication would be avoided. So this patient was actually not a surgeon, he was a gastroenterologist, a physician, and he suffered from some neurologic disease. So I remember it as a nightmare, because he was suffering so much from disability after my 2 operations. So to me it was so since then I close all defects. I know that the closure of all the defects does not prevent the hernias in 100%, but I think it's enough to see one complicated case of internal hernia to make surgeon to start closing all the defects, because you can see the consequences of and danger that you can prevent by closing those defects. At least if you do the closure and there is still a possibility of development of the hernia, at least you feel that you did what you could do.
So my question regarding this, yes, definitely you have mentioned, so before closing the defect, you have faced such a situation. Now you are closing all the defects. After the closing, have you any experience of internal hernia?
I think yeah, still there are several patients that I know, my patients that I closed the defects still came with an internal hernia.
Yeah.
As I say, it's known that it does not prevent the development of internal hernia in 100%, but it does decrease the chances of development of the internal hernia.
Sir, now we will talk about some post-op or post-op care or post-op follow-up of these patients. What's your protocol about post-op endoscopy after Roux-en-Y gastric bypass? Have you any protocol?
We do not have a routine endoscopic surveillance after gastric bypass, but obviously, in many patients who have any symptoms, we do perform an endoscopy. And I think we perform an endoscopy in many patients. The most common complication is just pain, postprandial pain, and the suspicion of the marginal ulcer. Patient who comes with a bleeding. So we do perform an endoscopy, but we don't have any routine surveillance after a gastric bypass in a patient who has no symptoms.
Sir, in symptomatic patient, when you did endoscopy, have you any data? All of these patients were H. pylori positive before surgery or now also positive? Have you any comparative study or data about these patients?
I cannot answer this question. I don't know.
So we can, if you ask your any fellow, so maybe they can search about this. So if a patient is now with the marginal ulcer after Roux-en-Y gastric bypass, so now also H. pylori positive, maybe in previous also before surgery patient was then, so we can make a protocol and we can also follow up these patients with the more as compared to others before going to, so we can make a protocol. If patient is H. pylori positive before surgery, we eradicate H. pylori, okay, but again, we must go every 6 months, every year. If patient is still asymptomatic, so go ahead for endoscopy. Sir, another question regarding, so this is also a little technical question about marginal ulcer. We have discussed about this. Have you any data? Which percentage of your patients, now your number of Roux-en-Y gastric bypass is tetrafigure, so definite more than 1,000. Tetrafigure is a very attractive figure, and your patients are more than 1,000. Have you any data? So which percentage of your patients are suffering with marginal ulcer?
I cannot say the exact number, but my feeling that it is a common problem after a gastric bypass, especially after long time after the operation. I have now patients 15 and more than 15 years in the follow-up. They come to me with a marginal ulcer, sometimes after severe bleeding. Patient goes for a vacation and hospitalized elsewhere. For example, I had recently a patient that I performed on him in 2007, and he went to Canada and was hospitalized with severe bleeding from marginal ulcer, and after he was treated, came to me. So my feeling, in the literature, they say that the rate of marginal ulcer could be from 1% up to even 10%. I think it is more close to the upper number of, it's definitely more than 5%. And it depends on the length of the follow-up. If we follow all our patients for more than 5 or 7 years, we will see a large number of marginal ulcers. And it is a real problem if we have a patient who is not smoking and who is not taking any non-steroidals, so we have no real risk factor for the marginal ulcer, and he's already taking some PPI, and he still suffers from the marginal ulcer. We don't really have a good solution for this patient.
Sir, how long time you prefer PPI after Roux-en-Y gastric bypass?
I give all bariatric operations, I give the same of the course of 3 months of PPI, full dose. I know there are surgeons who give for 6 months, even for 1 year. I follow, at the first year, I follow all my patients. So I give them for 3 months, and after 3 months, I try to stop. If there are symptoms, I continue the PPI. And if it happens frequently that patient comes and he says, I stopped my LOSEC or my Nexium, and the pain, epigastric pain came back. So what should I do? So I usually continue it for longer time. And after that, if the pain continues after stopping, I send them for an endoscopy. But I think what you said is a very good, that's a very good idea to have a routine endoscopy screening, especially for patients who were HP positive before the operation, because I'm sure HP is a risk factor too for the marginal ulcer postoperatively.
Yeah. Sir, regarding, so have you faced any intractable marginal ulcer after Roux-en-Y gastric bypass and there was no response to conservative therapy, and so you did a surgical intervention? Can you share any experience and what you did for that patient?
Yeah, I have several patients that suffered from intractable marginal ulcer despite full treatment, all possible medical treatment. And even patients who suffered so much that they came to the condition of malnutrition, could not eat. Every food causes them severe pain, and they have ulcer, 2 centimeters ulcer in the anastomosis. So I have an experience which is not very positive of performing several operations on those patients. And what I did is just a resection of the anastomosis and making a small pouch, gastric pouch shorter, but performing again the Roux-en-Y gastric bypass. So I remember at least 2 or 3 patients that I was happy at the beginning, but then I heard that they were operated again for a perforation in a different hospital. Yeah. So I can conclude that when there is a real intractable ulcer after Roux-en-Y gastric bypass, probably the resection of the anastomosis with the ulcer and performing Roux-en-Y again is not a good option. So I also have an experience of performing a completion gastrectomy of the pouch and performing esophagojejunostomy, like in complications of the sleeve gastrectomy when you have a very, very protracted leak. And in those cases, I think I have 2 cases of completion gastrectomy for pouch together with the anastomosis and converting the gastrojejunostomy into an esophagojejunostomy. So in this case, I did not have repeated ulcers. And I know that another solution in this condition is converting the Roux-en-Y gastric bypass into a sleeve. But that's a more complicated operations because we have to do a gastrogastrostomy, resection of the anastomosis, resection of the roux limb, and usually those patients could gain a little bit weight after the conversion to the sleeve after some years. But that's really could be a real complicated issue. Patient with an intractable, complicated marginal ulcer.
Yeah.
Still no good solution. No good surgical solution.
Yeah. Thank you, sir. Sir, Professor Laurent Layani is also live with us, and great honor. Sir, this is regarding this, you have mentioned, so this changing to sleeve gastrectomy is little difficult in such a situation, and you will prefer that esophagojejunostomy if there is intractable marginal ulcer. Sir, next question regarding weight regain. So you have mentioned already, because before going to increase your BP limb, so your patient were suffering with weight regain. Just my question, in such a case, what is your preference? What you will do? You increase BP limb in such a case when there is weight regain?
Well, it depends, because when we have a failure of the Roux-en-Y gastric bypass, there are many possible solutions. Not all solutions are good and not all of them are efficient. We know there is a possibility of putting a band.
Yeah.
It could be an adjustable band. It could be a minimizer band on the gastric pouch.
Like this.
There is a danger of erosion of the band into the gastric pouch. There is a possibility of redoing the anastomosis if the anastomosis is very dilated, to perform a new anastomosis, which is more narrow, to resizing the pouch, to make the pouch narrow again. But I think all those solutions are not efficient enough. And if the patient has a real weight regain, like losing 50 kilograms and then gaining 40 kilograms or even 50 kilograms back, that means putting all the weight gain, all the weight back. Today, I perform a conversion to SADI. Either do formal duodenal switch, but today I do more SADIs. Complicated operations. There are several possible techniques. I'm aware of 3 different types of techniques. One is Garnier. Another one is Amit Survey from I think is from Utah. There is a group in the United States that perform a lot of SADIs. So they also published a series of, I think maybe up to 20 cases of conversion of Roux-en-Y to SADI. And also there is a technique by a French surgeon, Topar, also for conversion of Roux-en-Y into SADI. So I think also there is a possibility of distalization of the jejunostomy, converting it into a ileoileostomy, elongating the biliopancreatic limb. But in my small experience, the elongation is not, it is either not sufficient enough or it causes a lot of complications. The patients have really severe diarrhea, severe mineral malabsorption. And I know that there are several papers by Sugarman that they say it's actually a conversion into a distalization of the Roux-en-Y gastric bypass. He describes that up to 50% of those patients actually required reverse again because of the malabsorption. So my preferred technique today for cases of Roux-en-Y gastric bypass, failed Roux-en-Y, is a conversion to SADI. But also I want to say that nowadays we have some efficient medications. So from the beginning, I put those patients on a Saxenda, on a GLP-1 inhibitors. So if they succeed in losing weight, I try not to operate on them. But there are several other options, as I mentioned. I think putting a ring is also could be efficient, but the really efficient option is a conversion to a more malabsorptive operation, like a duodenal switch or single anastomosis duodenal switch.
Sir, thank you, sir. Regarding Sadi, yes, this is a little difficult surgery, definite, and need more expertise. Just imagine patient with weight regain after Roux-en-Y gastric bypass. Roux limb is 100, and also our BP limb is 50. That was the routine just 2-3 years ago, and still many of surgeons, they are doing like this. And when you measure the small bowel length is about 8 meter or 800 centimeter. In such a situation, if just we cut that Roux limb, and so we save 4 meter or 5 meter of elementary, we can increase, I think, near to 2 meter of BP limb. Maybe that will be effective when you save at least that you have mentioned earlier, article of Professor Nomeri. So if we save 4 meter of elementary limb, it means Roux plus common channel must be 4 meter. Then maybe then we will face less complication of malnutrition. Are you agree, sir?
I agree. Yeah, could be. That requires measuring of the whole small bowel length. Personally, I don't have any experience of doing elongating the alimentary limb and keeping the 4 meters of total alimentary length. So I only can describe this experience from the paper of by Professor Nimeri. But I think if you know, I really don't know. So I personally prefer performing a very more efficient operation, which is Sadi. It's really more complicated, but I'm you know, I am an proponent of Sadi. So I have now a good experience with Sadi, and I think it's good operation. No, you know, has no bile reflux like in mini bypass. No marginal ulcers, no dumping, more complicated. But I believe that elongating the biliopancreatic limb and maybe also the alimentary limb, keeping the 4 meters of total alimentary length, could be a good option.
Yeah. Sir, so much thanks. Thanks. Really, I take your time, and it was, I personally, I have learned a lot. So we are going to finish. Really, I like to talk more and more. But due to time, and I know you were also tired all the day. Sir, my question regarding your main concern after Roux-en-Y gastric bypass, after about 2 decades, now you have a lot of experience, and someone who have started his bariatric surgery journey with Roux-en-Y, and then progressively shift to one anastomosis gastric bypass. Why you have shifted your practice to one anastomosis? What was your main concern after Roux-en-Y gastric bypass?
It's a difficult question, but I think at the end, mini gastric bypass, the single anastomosis gastric bypass, is a simpler operation. You avoid internal hernia. It is not a complete absence of internal hernia, because we have case reports of, and I also know of my patient that developed an internal hernia after single anastomosis gastric bypass. But still, on average, it is an operation that has a much less frequency of internal hernia after some time. This is one of the benefits. Another benefit is the avoidance of two anastomosis. At the beginning, I was very, very against single anastomosis gastric bypass, because I said, what is this addition of jejunostomy? JJ is a simple anastomosis. Why do a different operation that is not, we don't have any knowledge about? But you know, the complications of JJ are rare. Those are really rare complications. But I think after 500 cases, I had my first complication, which was, it was not a narrowing, but it was some kind of kinking, probably because of some narrowing. And I had to reoperate this patient. And after 1 year, I had again a complication of JJ. And I was already performing some few mini bypasses. And after thinking, you think, you know, after you have a complication, you go, you relax after the patient is already okay. You think, how could I avoid this complication? So one of my thoughts is that still, even rare, one case out of several hundred cases, still there is a complication of jejunostomy. So the operation mini bypass is a simpler operation. Also, I think the tailoring of the length of the biliopancreatic limb in a single anastomosis gastric bypass is much easier. There are many papers by several different authors that we should measure the whole intestinal length and to make the tailored BP limb in a mini bypass. And in gastric bypass, it's less predictable. So the weight loss in mini bypass could be better if we do some tailoring for the length of the limb. And one more benefit of mini bypass over the Roux-en-Y gastric bypass is the what did I thought forgot.
No issue, sir. So definite. So due to this, so you are now preferring one anastomosis. So my question regarding, because nowadays, if someone is suffering with bile reflux or reflux after one anastomosis, or someone is suffering with GERD or reflux after sleeve, what we ask, so go ahead for and change, convert to Roux-en-Y gastric bypass. So it means nowadays Roux-en-Y is one of the rescue operation in such a situation. What is my question? What is your prediction about Roux-en-Y in future? Is it will be just rescue operation or no? Still here, this operation has space till 1 decade. So maybe after 1 decade, one anastomosis gastric bypass will replace Roux-en-Y gastric bypass. What is your prediction?
I think it will not disappear. I think Roux-en-Y gastric bypass has its position in the bariatric surgery armamentarium. It will always be a good operation because it's still it is the oldest operation we have, and it's a time-tested operation. Has a very good record of consistent results in a patient with a BMI between 35 and 50, not BMI above 50, but in average patient with a BMI of 40, 42, 45, it can give a very good result. And I think that the bile reflux in mini bypass is also it's a complication that has some risks. So we know that there is no best bariatric operation. We know there are benefits in every operation. There are benefits and there are downsizes. So Roux-en-Y gastric bypass has its own benefits, and I think this is an operation that will stay forever with us. And still, there is also a place for a mini gastric bypass. I think bariatric surgeon must be proficient in performing mini gastric bypass and Roux-en-Y gastric bypass and sleeve gastrectomy. And once he is able to do all of them, he can choose the best operation basing on his experience that will allow him maybe to go to do the best operation for a specific patient.
Sir, so much thanks. Really, it was a great session. And personally, I have learned a lot. Your message for our youngsters, if someone is now going to start bariatric surgery, especially Roux-en-Y gastric bypass, what will be your message for those youngsters?
I think it's a good journey to start performing Roux-en-Y gastric bypasses. So what is important is to choose easy cases at the beginning, to have a good training. And after you have a training, you can start doing on your own. Avoid high BMI males, central obesity, big fatty livers, stay with the young females, average BMIs of 40, not above 50, healthy patients who don't have any severe complicated diabetes or complicated, I don't know, abdominal operations. And after you do 50, 70, 100 operations on the easy patient, proceed to more complicated patients, to revisions, to more complicated male, because we know all males usually are more complicated cases. We know that male bariatric patients have a higher mortality too. So have good training, choose easy patients at the beginning. Obviously, it is a very individual suggestion, because someone who has a very good laparoscopic experience maybe have only to do maybe 10 cases under supervision of very experienced bariatric surgeons. But someone who does not, maybe he needs 100 cases. So good luck with the beginning. And one more tip is to make your pouch longer, because if you don't see that the patient has a very long distance between the small bowel mesentery and you make your pouch short, it would be very hard to perform the gastrojejunostomy. So always look at the mesentery of the small bowel and look at the distance. If you see the distance is long, do your pouch longer. It's better for a patient to have easy gastrojejunostomy and not to leak than to suffer from a reflux if you perform a bigger pouch or something. That's one of my tips too.
Sir, so much thanks. Really, it was one of the best session in my opinion. And so much thanks, sir, for your cooperation, for your support, and definitely in future also we need your support. And thanks my viewers also now this time in India and South Asia and Middle East is a late time, and also from Europe also, yes, evening time. And viewers, so much thanks. This all sessions and this academic activity is due to your support, because always you support us and we need your support. If you have any question, you can ask in comments. We will continue our series of Roux-en-Y gastric bypass every Tuesday, 10 p.m. Dubai time. Next week, again, we will be with another legendary bariatric surgeon. So we need your support. If you have any question, you can ask in comments. And also you can contact with me directly. Sir, so much thanks again for your support, and definitely in future also, we need your support and guidance.
Thank you very much. It was
so much thanks, sir. Have a nice time, sir. Thank you, sir. Thanks a lot. Bye-bye.